Let's talk about randomised trials for social policy, because that's what they wanted, and then we'll talk about drugs in a second, because that's what you want. Okay, so I've just done this Cabinet Office paper with a bunch of people from the Behavioural Insights team arguing that we should do more randomised trials of policy in government. And that's an idea to which there is an enormous amount of resistance, both from, I think, the civil service, but also from a lot of social scientists who object to the idea of this tool, which is the best way we have of finding out if an intervention works or doesn't work. There's a lot of resistance to doing that in a policy domain. Now, this is a kind of cultural aberration. So, for example, in web design, even somewhere as bland as that, it's actually very common. You might have seen on Wikipedia recently, there's a picture of Jimmy Wales at the top for the fundraising drive. And that's because he's like quite a shy person, he finds it really embarrassing, but they did a bunch of A/B tests. So they had a starving child in Africa and a thing saying, you know, she could get access to more knowledge for free if you support Wikipedia. They had a hot girl, they had a hot man, and what they found was a picture of Jimmy Wales got the most clicks and the most donations in these random A/B comparisons. And so that's what they went with, and that's how they maximised their revenue. We do it all the time when we're testing drugs and medical interventions. So if you want to find out what the best treatment is for a particular medical problem, you just get, say, 200 people who've all got that medical problem. You get 2 interventions where you don't know which is the best for that group of 200 people, and then you randomly assign them. So half of them get one treatment, half of them get the other, and then you measure their outcome. You measure whether or not they get better by a pre-specified outcome at the end, and then you've got your answer. Now, this is really powerful because it excludes all other alternative explanations. It's the method that's the most free from bias. And that's because if you don't randomly assign people to one treatment or another, you can find that they are, for kind of reasons that are often very difficult to predict, not comparable. So, for example, for a long time we thought that long-term HRT was really good for you. We thought that it reduced your rate of death, it was better for fewer heart attacks and so on. And that's because when we looked at the people who got long-term HRT and we compared them against the people who didn't, we found that they lived longer and had fewer heart attacks. But the problem was, when we finally did a trial, we found out that the opposite was true. HRT was actually killing people. Long-term HRT, not short-term HRT. We found out that HRT was actually killing people, and the reason it had appeared to be beneficial is because the people who were getting long-term HRT are the kind of people who were already health-conscious, assertive, posh, and living healthier lives for all kinds of other reasons, and they were the ones who were going to their GPs and asking for long-term HRT, or even advocating for it, because GPs were often reluctant to give it long-term, and so that made HRT look better than it really was. Now, there was a lot of resistance to getting trials into medicine, even as recently as the 70s and the 80s. So Archie Cochrane, the guy after whom the Cochrane collaboration is named, he is the kind of great-grandfather of evidence-based medicine. And he describes in his autobiography, which I highly recommend, called Non-Random Reflections, his difficulty in trying to get randomised trials taken on by medics. So, for example, he would go and see surgeons, and he would find that surgeons would have completely different ideas of the most effective operation for completely identical patients with completely identical presentations. And he'd say, well, how do you know that this operation that you do is the best? And they'd say, because I'm the professor of surgery at St Mary's. Are you insane? Of course I know. I'm a world expert. Then he'd go and see somebody else down the road, and they'd have a completely different idea of the best operation. And they'd say, well, I'm the world expert because I'm the professor at St George's. And then finally you got them all in the room, where they were all insisting that they were experts, but there was no real grounds, there was no evidence for them to disagree. I think he said it was like having a psychiatric ward full of Napoleons, right? These people were constantly bickering, and he had to go through huge battles to get people to accept that there was uncertainty about the things that they were doing. He describes also in his autobiography going along to, so trying to set up a trial comparing coronary care units against people being sent home to their GP after they had a heart attack in the 70s. So this is in the old days when we didn't actually have very many useful treatments after you'd had a heart attack. And so coronary care units could quite plausibly have been a place where you were getting lots of excessive medical intervention but for no actual benefit. And that's what he suspected. So he tried to set up this trial. All of the cardiologists working on the coronary care unit said, no way, you must be mad, you're a murderer, you're depriving people of our specialist care in these coronary care units. But they did the trial anyway, and when it came to report the results, he put them up on the board, and he said, well, I'm really sorry to have to tell you, it looks like you were right. And actually, being sent home does result in people having worse outcomes. It looks like sending people home is actually killing them. And there was this uproar, they were sort of hurling abuse at him, calling him a murderous bastard. And then he went, only kidding, and pulled it down. And it turned out actually that coronary care units were killing people. And this sort of stony silence. Archie Cochrane did die, he said, without the consolations of either a wife or a merit award. He was quite a cheeky, provocative human being. So it hasn't always been easy to get doctors to accept that we don't know what treatment is the best until we've tested it. But that battle was finally won, I think, maybe 25, 30 years ago. But in policy, that battle hasn't been won. And that's a real problem, because often the things that we do don't actually work as well as we think they work. So in the Cabinet Office paper that we've just done, which I really recommend, like it is like a pop science guide, it's the Ladybird book of policy trials. In that, we describe some trials that have been done recently, which have, I think, some quite chilling results. So, for example, there's one randomised trial comparing 2 different strategies to get people back to work after they've been on incapacity benefit. It costs about £1,400, and it turns out that the new intervention, the new expensive one, doesn't increase the rates of people coming off incapacity benefit, and so we were wasting £1,400. But it's not just that you can waste money, you can also do harm, even with very good intentions, in both policy and in medicine. So one example from medicine is steroids. For a very, very long time, we thought that we should give steroids to everybody who had a head injury, and that made perfect sense on paper if you think about the kind of theory of it. So when you've had a head injury, your brain swells up, and your skull is a fixed-sized container, so it just starts to crush your brain on the sticky up pointy bits at the bottom of your skull. So steroids, we know, reduce swelling. That's why you get injections in your knee if you've got a swollen knee of steroids. So what we did for 20 years was give everybody who had a head injury steroids on the assumption that that would reduce the swelling in their brain and save lives. When Ian Roberts at London School of Hygiene and Tropical Medicine tried to do a trial on this, everybody said, you're a madman, you're a murderer, you're going to kill people because we know that this treatment is effective. And he said, well, how do you know? For all you know, it might be ineffective, or it might even introduce side effects, adverse unintended consequences. Finally, when he got permission to do a trial, it turned out that he was right and they were wrong. Steroids were killing people, and they were killing people in actually very large numbers, because head injury is a very common presentation and steroids were a very common treatment. So by not knowing, we can inflict enormous harm. And that's demonstrated, I think, also by a policy trial, which we describe in the paper, where, with the best of intentions, assuming that it would work, people had rolled out a programme of giving incentive payments to attend adult education classes. And it turned out, when finally they ran a randomised trial to compare whether giving incentive payments or not giving incentive payments results in better attendance rates, it turned out that giving people incentive payments to attend adult education classes reduces their attendance. So we were spending money and actively harming people's lives with that money that we were spending. So it's really important to be humble. And humility, I think, is where most of the objections to randomised trials come from, or rather an absence of humility. So the things that people say when they're trying to argue against doing trials are, for example, firstly, they'll often say, well, look, we know what works. Of course I know what works. That's the sort of thing ministers say, right? So of course we know what works, and this is what we're going to do. Actually, strategically, if you want to get randomised trials done, I think the real key is not to do them on big controversial areas, but to do them on very trivial, boring, marginal issues. And that also makes them much cheaper. So in this paper, which I'm going to advertise about 50 times during the next 6 minutes, in this paper we describe one extremely elegant trial which cost basically nothing at all, but is going to save the Exchequer tens of millions of pounds, right? The key to running a really efficient trial is to identify a source of follow-up data that is routinely collected administrative data, and to identify 2 things that can be compared against each other where there's no difference in cost, and it doesn't cost anything to have 2 of them at the same time. So the trial I'm thinking of is a trial that compared 2 different forms of reminder letter to try and get people to send their tax returns in on time. So getting tax returns in on time is really important for planning the workforce in Treasury, or in HMRC rather. So 2 different kinds of letter. Doesn't cost anything to change the wording of the letter that goes out, because everybody's getting the letter anyway. The date on which people send back their tax return is already recorded in routinely collected administrative data, and it turned out that with just a few tweaks to the way that you phrase look, come on, hurry up, you've got to give us your tax return, it's getting late now, you get people's tax returns in much, much faster. And that trial cost nothing, and the Permanent Secretary is now implementing changes that were found from that trial because it's going to save lots and lots and lots of money. So people think that they already know what's going to work and they refuse to do trials. People think that trials are expensive and they're wrong, so they refuse to do trials. The last objection I think that people make, this is so chaotic, sorry about the last objection that people make is they say it's unethical to run a trial, right? It's unethical because you're depriving people of this brilliant new thing. And again, I think that flows from an absence of humility, because first of all, we don't know if the new thing is brilliant until we've done a trial. We don't really know if one thing works better than the other. And also we don't know if we're wasting money, and we don't know if we're inflicting harm on people. But lastly, things are very, very commonly rolled out in a kind of piecemeal basis anyway. It's actually very, very common that some parts of the country will get a new intervention before other parts of the country. And this is what people call a postcode lottery, right? The problem is, I wish it was a postcode lottery, because the problem is, it's not arbitrary, it's not random. And that's exactly why you have to do a trial. If you imagine, for example, running, you're bringing in a new intervention that's supposed to get people back to work when they've been long-term benefits claimants. If you don't do a trial, there are only two ways of trying to measure if that policy was successful or not. The first thing you could do is you could just roll out your new back-to-work intervention to everybody in the country, and then try and compare the rate at which people come off benefits after you've brought it in to the rate at which people come off benefits before you brought it in. But if you do that, then unfortunately, you've got no way of disentangling whether the unemployment rate is going down because of your brilliant intervention or because of changes in economic conditions that were going to happen anyway, or that were happening anyway. The only way that you can try and untangle those is by building some kind of really complicated, actually very expensive and unreliable economic model that tries to draw all of these factors in together. And even at the end of all of that expense and complication and effort, you still won't get a good answer. But the other thing that you can do that's not a postcode lottery is you can say, well, we'll roll it out in pilot schemes. And what people sometimes do is they roll out pilot schemes and then they compare the people in the job centres in the pilot schemes and their rate of getting off job seekers allowance against the people who weren't in the pilot scheme and their rate of getting off job seekers allowance. But the problem with that is the job centres that participate as early adopters in pilot schemes are freaks, okay? They're not like normal job centres. They're the really good ones. They're the ones with the ambitious staff that are highly motivated, that go, yeah, we'd love to roll out this pilot scheme. We'd love to be early adopters. We'd really like to help. And similarly, maybe if your pilot scheme is voluntary to enter, then maybe the people who are on benefits, who volunteer to be in this pilot scheme, are also going to be very unrepresentative. So that's why you have to do a randomised trial. Does that make sense? Will you now do as I say? How much longer have we got? Three minutes. Oh, right, Adam. Do you want to talk about drug companies for 3 minutes and 48 seconds? Okay, so there are three very, very, very big problems in the way that we run medicine in the UK that have never been fixed and that cause unnecessary harm in terms of unnecessary suffering by patients and unnecessary death, but also unnecessary waste of money. The first problem is unflattering trial results don't get published. So drug companies can do as many trials as they want, and if they come up with a result that doesn't make their drug look good, they are still perfectly entitled to brush them under the carpet. People have tried to fix this in various different ways, by having trial registers, by having laws about compulsory publication, although only in America, not in the UK and Europe, but all of them have failed, and they failed in boring but very important ways, which I'd be happy to tell you if I didn't have only 2 minutes and 58 seconds left. We know that roughly half of trials get buried, roughly half of trials go missing in action, and we know that trials with positive flattering results are about twice as likely to be published as trials with unflattering results. And this is not trivial. So for example, one antidepressant which I myself have prescribed to patients, I've signed my name on a chit after I'd read all of the literature that was available to me in the published academic work. As far as I could see, this was a safe and effective drug. Reboxetine, it had 2 trials, comparing it against placebo, where it was better than placebo, and it had 3 trials comparing it against other antidepressants, where it was equally effective. But it turned out that they'd done 7 trials comparing it against placebo. 5 of them had shown that it was rubbish, 2 of them had shown that it was better, and only the 2 that showed that it was better got published. Similarly, they'd done about 12 trials, I think, comparing it against other antidepressants. 3 of them had shown that it was equivalent, and they got published. The remainder had shown that it was worse than those alternative drugs, those other antidepressants, and those studies didn't get published. To my mind, this is criminal, this is unethical, and this is leading to the unnecessary deaths and suffering of uncountably huge numbers of people, because it covers every single corner of medicine. Tamiflu is a drug on which governments around the world have spent billions and billions of pounds stockpiling, and we've done that on the promise that it will reduce the rate of complications of flu. So that means pneumonia and death. But the evidence on that has been withheld from the Cochrane collaboration by Roche, and is still being withheld from the Cochrane collaboration by Roche. This is an extraordinary thing. This is a drug which we have spent hundreds of millions of pounds on. It almost defies belief. 1 minute and 11 seconds left. The remaining 2 problems are, firstly, we have obsessive secrecy in regulators. So risk management plans, which are the documents that drug companies use to transmit safety data to the European Medicines Agency and the MHRA, are held in secret. It's extraordinary and it's unforgivable, but that's the reality. The European Medicines Agency runs a clinical trials register, which is a place where you can see all the trials which have been conducted and completed, and then try and match them against the ones that have been published, so that you can see if any have gone missing in action. The European Medicines Agency's clinical trials register, that covers the whole of Europe, contains 38,000 trials, but it's held in secret. This is a transparency tool that is held in secret, and it is contemptible and ridiculous. And I genuinely believe that when the public find out what we have all collectively acquiesced in regulators, in the civil service, as doctors and as academics, they will be appalled and horrified. And I've got a book on this on the 27th of September, so we can find out if I'm right or not. Maybe people care. I don't know. But the last problem is, drug companies are the people who educate doctors. So you go to medical school for 5 years, you're in training for somewhere between 3 and 8, and then you're out there. You practice medicine independently for 4 decades, and there is no budget for continuing medical education, or what there is a trivial sum. And so doctors are paid to go to conferences, they get posh travel, posh hotels, they get continuing medical education, CME, or continuing professional development, that's paid for by key opinion leaders who are academics who are in the pocket of drug companies, paid to go to them and tell them how fantastic their drugs are. And it's extraordinary and unforgivable, and it costs lives. Thank you very much. Do you have questions, or are you being TED?
Being TED, but you have to rush off, don't you?
I'd answer questions if you had any, but I don't want to subvert the TED.
I think we can take a couple of questions.
If there's anything being real TED,
We'll pause the TED, and if you
okay.
want to take questions, if there are any.
Hey.
What do you do when there is some more no data to be able to do kind of like that?
But you do a trial when there is no data. I mean, you do a trial when you don't know. That's exactly when you do one. And actually, I think, so there's a complete absence, I think, in policy of an information architecture that facilitates rational evidence-based policy making. In medicine, we have things like DUET, which is the database of uncertainties about treatments, right? A bunch of academics and doctors and patients all get together in different fields of medicine, and they go, right, what don't we know about rheumatology? And they write a big list, it's like a wish list, a database of uncertainties that can then be addressed with research. And that's kind of part of how places like NIHR prioritise research. I think in government what we need is a database of uncertainties about policy interventions, where you can say, well, you know, we don't know if the following infinity things work or not. And you know, for every new policy, I think it goes without saying, actually, that wherever possible, it should be rolled out in the context of a randomised trial. And one of the best things that this government have done, I think, is firstly to recognise that, and Francis Moore is sort of pimping our paper at the moment, which is nice. But also, Lord Freud introduced in his, I think it was a bill, this very, very important but quiet kind of nerdy corner of the commissioning process, which said that when you commission new services, you must commission them from providers who are capable of giving you variation in service for the purposes of research. So I think every new intervention, every new policy that is rolled out, people should be thinking, how can I do a randomised trial? And a randomised trial doesn't mean, like, you know, give some people cake and free money and give somebody broken glass and poo to walk through on the way to work, right? A randomised trial means really modest changes between the two treatments that you're giving to an individual. So, for example, you can hugely increase the rate at which people pay their fines, their court fines, by sending them a couple of extra reminder text messages and by changing the content of those text messages. And that cuts down on the costs of people going around to take away their DVD player and their television from their house. Not just the financial costs of doing that, but it also cuts down the social costs of doing that. And you wouldn't have known that if you hadn't done a trial. And doing a trial comparing, like, Ben, you haven't got around to paying your court fine, and you haven't paid your court fine in a text message. Like that very modest difference between the two. There's nothing difficult or challenging technically, and there's nothing ethically problematic about doing that. It's just an absence of a culture of testing things. Hi. So the trouble with health is it's an area where there's kind of more of a culture of people doing trials, because it kind of the practice of doing randomised trials seeps along kind of cultural fissures, and so for that reason I think there are more trials in medicine than there are elsewhere. So that's why, for example, you'll find people doing randomised trials of schools interventions to try and prevent teenage pregnancy, because you know the follow-up data there is from GP records, and everybody around is kind of into health stuff. So there's more stuff in health that is properly tested than that's not. It's kind of almost banal to say that it is. But there are endless examples of things that could be tested in cluster randomised trials, and I think a lot of policy changes could very easily be done that way. Actually, if you've got 50 different clusters around the country where you can roll out different interventions, then you're in a good position. One thing that I think is interesting to watch is the changes in the way that services are being commissioned by GPs and all of that stuff. I think will break Lord Freud, isn't it ridiculous? But anyway, will break Lord Freud's edict that publicly purchased services must be purchased in a way where there can be explicit variation in services for the purpose of research. I think it would just be like ad hoc and random, not random, not a postcode lottery. Hi.
Hi. What do you think will happen when that sort of desire and the evidence for the random policy trials butts up against sort of ideology of certain ministers wanting to do something because that's their ideology? How would you argue sort of against that?
So I don't think you do trials in that situation. Like if you play Go or Risk, like you take over the easiest part of the territory on the board as early as possible, and then you fight over the details, right? And we're still at the stage of doing easy trials in situations where they're not controversial, because I think what you have to do is make randomised trials completely routine, a completely normal method of assessing whether or not one intervention is better than another. And once you've done that for 5 years, 10 years, and you've demonstrated cost savings and benefits, and you've demonstrated that you've avoided inflicting unintentional harm on people, then I think you're in a much stronger position to just say, well, why on earth don't you do a trial on this bonkers new idea you've had around education or health or benefits or whatever. But it's also really important, I think, to remember that there's a real difference between a randomised trial that lets you test whether some new piece of ideology successfully attains its stated goal, and running some kind of test to measure whether somebody's ideology is actually kind of morally and ethically sound. You can't do a trial on whether somebody's ideology is correct or not. So if somebody says, I just really hate it that people are on benefits and don't work, and I'm going to make them do compulsory labour, even though that doesn't increase their chances of finding a job in the future, because I don't care about that, I just hate that people don't work, then there's no point in doing a trial showing that it doesn't increase employment afterwards, because they don't care about that. You know, and I think that's kind of at the core of a lot of the conflict that you get between evidence and policy. So with David Nutt, for example, the head of Advisory Council of Misuse of Drugs Act, you know about this, where he was sacked in what was called the Nutsack affair, by me anyway. The problem there really was ministers, that, you know, David Nutt was saying, look, drugs being illegal, firstly, doesn't reflect the relative safety of different drugs, which everybody kind of knows anyway. But he also said, secondly, I think crucially, he said, drugs being illegal does not achieve your stated objective of reducing the overall use of drugs in the population, nor does it achieve your stated objective of reducing the total amount of harm that is done by harmful drug use in the population. And it was, you know, clear and well argued, and I think I'd probably agree. And he was sacked. And he was sacked, I think, because nobody in government was willing to say, that is true, but I don't care. You know, they wanted that evidence to go away. And that's a kind of different and difficult problem. Because sometimes, if you're mass evidence, you can put people in a corner where they're really stuck, having to like fully swallow the true ramifications of what they are asserting. And in this case, it was nobody was willing to stand up and say, I just really want to say drugs should be illegal, and I don't care if that means people carry on taking drugs, and I don't care if that means that paradoxically there is more harmful drug use around, because it's just much more important to me that we just say drugs are bad, because that has some kind of other abstract, brilliant benefit that is more important than the junkies in Camberwell dying. You'd like me to shut up, wouldn't you? Oh.
Take one more question.
Just one more. I wondered, with respect to your forthcoming book, what actions you're hoping that individuals will take on learning the news you're going to break.
Okay, so there's a whole set of instructions for each profession in the book. And then there's like, what do you get, like the man on the street to deal with the woman on the street? I'm so, God, that was dreadful. What do you get the person on the street to do? And that's really difficult, because, you know, it's political change like any other. I think it's very clear what changes there have to be at a policy level. I think you just need massive mandated transparency, and you know, there's a clear justification for this. So you need to say all trials need to be published within 1 year of completion, and you need to enforce that by all kinds of different things. You need legal sanctions on drug companies that withhold data, but also I think ethics committees who spend endless hours finicking around on complete irrelevancies and setting up spurious barriers to life-saving research. I think one thing that they do need to do is say to everybody who's involved in a trial, is any one of you involved in a trial that is still withholding data more than 1 year after completion of that trial? And if so, you're not allowed to touch any more patients, because you're exposing people to unnecessary avoidable suffering and death, and that's a real no-brainer to me. Similarly, I think that all of the kind of royal colleges, like the one we're in right now, have been, you know, profoundly irresponsible in not stating very clearly in their code of conduct, we consider it to be research misconduct to withhold trial data, because it results in unnecessary suffering and death for individuals, you know, who don't know what the true effects of the treatments that we give are. So all of that, I think you have to be much clearer about fixing the problem of negative results being withheld. I think on doctors being educated by drug companies, which we know, incidentally, is associated with doctors making biased decisions. So doctors who are taught by drug companies are more likely to buy that drug company's product. And it's insane and deranged. Doctors that are flown away on holiday are more likely to buy that company's product, right? And I genuinely believe that this is an area where we could very easily see an enormous culture shift, where things which were perceived to be normal within the profession for a very long time, when outsiders suddenly look in, they will just say, what on earth are you doing? And that's what we've seen, I think, with the Leveson inquiry, with practices amongst journalists and amongst policemen and also amongst politicians, where they all thought this was perfectly normal, and now suddenly they're ending up in prison. And actually in Germany recently, 2 doctors were reported to the police by their hospital manager after they were flown away on holiday, and then they came back and they bought, I think, an MRI scanner from the company that had flown them off on holiday. And the German police just went, what are you doing? This is obvious fraud. We see this in other places. This is fraud. And that's completely routine practice for doctors and managers in the NHS today. When the new fraud regulations were brought in 2009, implemented into end of 2010 and 11, the senior police officer in charge of that said specifically that in his list of people who were priorities for targeting were doctors and NHS managers. And what a fucking astonishing state of affairs it is, right, when that is like on the table. So I think that we need to address that much more seriously, but also have more transparency. So I think every doctor in their waiting room should have a piece of paper prominently displayed that says, these are the names of the doctors, these are the foreign trips they accept, this is the education they accept, this is whether or not they see drug reps, this is the amount of money that they've had in total from those drug companies. And I think you should just have it completely clear up on the wall in your doctor's surgery. We need a simple centralised database, which I'm building through an organisation called Better Data, which will be empty and unpopulated, but where you can also have contact your GP and ask them why they haven't filled it out on the site. And I think everybody just has to declare everything. And I think that should be mandated in law, but until it's mandated in law, we police it with shame. Thanks.